Morning, everyone. Yes, I'm Jagdeep. I'm a geriatrician based down at Guy's and St Thomas's, but been involved in perioperative care for a number of years now. So yes, I was going to be doing this talk this morning together with Lisa, who's actually our policy manager at Cpoc and has been doing the majority of this work. So I was here to give her a nice intro, and then she was going to go into the detail of policy work. But I'll see what I can do to talk you through something that I've been learning a little bit about over these last few months, but clearly not an expert in this. So I think first of all, we probably ought to start off talking about what Cpoc, the Centre for Perioperative Care, actually is, because I'm not sure that everybody is aware of the fact that it's around and exactly what it's been doing over the last 18 months or so. So Cpoc is a partnership across all of the colleges who are involved in perioperative care. So ranging from, of course, anaesthetists, surgeons, physicians, nursing, general practitioners, but also involving a number of other faculties and associations and patients and the public as well. The centre has been established to promote, advance and develop perioperative care for the benefit of patients at all stages of their surgical journey. So that's the kind of main aim of the centre. You could ask, well, why is Cpoc needed when we have so many different associations, colleges, organisations who are involved in perioperative care? And really the reason for us for having set Cpoc up is because, as we've been hearing this morning, the perioperative pathway starts back out in the community, in primary care, follows the patient through primary and secondary care, interfacing between community services as well as secondary care-based services through the surgical episode, and then back out to the community. And what has been lacking over recent years and has become really obvious over recent years is the fact that we don't have an organisation that brings all of these other smaller organisations together and develops a coherent perioperative pathway that makes sense to patients and the public, and also supports us as healthcare professionals to develop perioperative care for the population who needs it. Now, when we talk about the population who needs perioperative care, it's really interesting, isn't it? In that, of course, we know that we're doing around about 10 million surgical procedures every year in the UK. Now, lots of those are going to be high volume, straightforward procedures, but they still need more streamlined, better pathways delivering quality care without variation. And we've certainly seen from the GIRFT data that even for pretty low risk surgery, we see lots of variation across the surgery. So for that kind of, the high volume group, what Cpoc really wants to do is to support organisations such as GIRFT at reducing variation across the country. And then at the other extreme, we know that we manage around about 250,000 high risk patients through their surgery. And for those patients, we need a very different approach. We need pulling together of services that can provide prehabilitation in the way that we often recognize it nowadays, addressing exercise, nutrition, and psychological preparation. But also within that, we need to embed medical optimization, as Sonia was describing anemia, but anemia requiring a diagnosis, requiring a perioperative management plan, using patient blood management approaches. So for that group of patients, we need a very different pathway, linking community and secondary care services. And again, that needs an organisation to start to support the development of those innovative pathways of care. So we think that the need for this kind of organisation is pretty clear. So whilst we think that it's needed, what are we actually going to do? Because of course this is a huge piece of work. If we're looking at that volume of patients across the whole of the pathway, how do we start to segment out what we need to do through Cpoc? And then how do we work with affiliated organisations to actually change clinical practice across the country? So to help those of us working at Cpoc, and I suppose actually at this point it's useful to kind of say who works at Cpoc. We have the director, who's Dave Selwyn, an anaesthetist based in Nottingham. Scarlett, who's a deputy director, surgeon, orthopaedic surgeon based in Portsmouth, and you'll be hearing from her next. Myself as a geriatrician based in London. Louise Bates, who's a clinical fellow. And then we have the administrative support through the college as well. Now, although that's a kind of, a number of us, it's actually a kind of one PA per person. So a relatively kind of light kind of team as such. But the team has been developing the strategy, working across the colleges and with the board of Cpoc, and identified these as being the main themes that we want to start to address. So looking at improving quality of care, empowering patients and their carers, supporting the workforce, influencing policy, and then looking at digital technology as well as research and innovation. So if you go onto the Cpoc website, you'll be able to see the overarching Cpoc strategy that goes into a bit more detail across each of these areas. If we reflect back on the last 18 months that Cpoc has existed, I've just started to list some of the work that we've been involved in and leading. So when we've been looking at quality care, we've started to think about the fact that we need to start to think about surgery in a different way. We've often thought about patients being surgical patients. Or surgical pathways, but actually the surgical intervention is probably just a punctuation, partly in the patient's longer term lifespan, but also in terms of the perioperative pathway as well. And there's also work to be done around kind of ownership. Is the patient under the care of the surgeon, or is the patient under the care of a team? And how do we start to address some of the cultural, behavioral, attitude kind of issues that require a kind of mind change from individual-based practice through to team-based practice? That needs to happen on a professional level, but it also needs to happen for our patients and the public as well. Patients often say to us kind of, whose care am I actually under? And of course, that's a hard question to answer when we're now working within teams across surgical pathways. So that's been some of the work, is starting to look at the cultural change that's required. Also, in terms of developing quality care, we need to start to revise the way that we approach clinical guidelines. Up till now, our guidelines have been very much specialty based. So we have the anaesthetic guidelines, or we have the surgical or the medical guidelines for specific conditions. But again, if we're going to start to switch to patient-centered guidelines, then we need to bring those organizations together and then start to outline what needs to happen at each stage of the pathway, who needs to be involved, and what we think is the best supporting evidence to implement into clinical practice. So last summer, we published the Enhanced Care Guidelines together with FICM. Earlier this year, we've published the Perioperative Guidelines on the Management for Patients with Diabetes. And currently we're working on guidelines for frailty and anemia, both of which should be published in the early autumn. So it's great having guidelines, and as we all know, there's loads of them out there. The next issue is really about implementation, and how do we get those implemented into clinical care? How do we support clinicians like yourselves at being able to develop the appropriate resources, the appropriate teams to be able to embed this? And certainly those kind of questions came out in this morning's session about anemia. How do we actually do this? So Cpoc is trying to help with that in terms of providing shared resources. So using the website as a place that people can go to have a look at case studies, being able to get people working together, establishing networks so that you know who down the road may have done something that you can then translate to your clinical setting. So that's some of the work around quality care. In terms of empowering patients and carers, we've been doing a lot of work around shared decision making and providing a coordinating role around the multiple organisations that have suddenly kind of sprung up looking at shared decision making and trying to help them to kind of focus in on how we can implement shared decision making again into clinical care. Some of you may have heard about the Cpoc concept of changing waiting lists into preparation lists, and certainly that's become a real issue now in COVID times with our waiting lists growing. And it's about how we use that time, first of all, to ensure appropriate shared decision making and trying to avoid patients expressing surgical regret. We know that about 1 in 7 patients actually after surgery say that they kind of really think that maybe that wasn't the right thing for them. So using that time to discuss the benefits, risks, alternatives, do nothing approach to whether surgery is the right option or not. And for those for who it is the right option, really using the time to get people as fit as possible, optimizing comorbidities in a coordinated fashion and together with prehabilitation strategies and implementing public health initiatives. And that's where we've been working with the Faculty of Public Health. And of course, that's all changing at the moment since COVID. So we're trying to input into the way that the new authorities might work within that field. Some of the work that we've been doing around supporting the workforce has been addressing the fact that, of course, we have an insufficient workforce, whichever specialty we look at. But even within our specialties, we probably at the moment don't have the right skills to deliver the whole of perioperative care. So we've now started work with Health Education England, of course, together with the colleges at considering further changes that need to be made at undergraduate and postgraduate curriculum, and developing the appropriate resources to do that. And some of that work has been also addressing issues around the alternative workforce. So who else can we engage to develop transdisciplinary teams as outlined in the academic AMCR college report around supporting skills-based medicine as opposed to professional-based medicine. And then there's been work around research and innovation. So of course, linking with national audit, big data, GERFT, but also starting to influence funding streams such as those through NIHR and ensuring sharing of work through the case studies. So quite a lot that's been going on over the last 18 months. But of course, if we're going to make lasting change, we do need to influence policy. And of course, with COVID, in some ways, this has now presented us with an opportunity to focus the minds of politicians around the need for the long-term transformation of surgical pathways. Now, what's really clear, kind of working suddenly in this new arena, is that we need to tell our story in a different way. And telling our story in a different way has been what writing the green paper has been all about. So green papers are something that people kind of are aware of within the policy world. And really what these papers do is kind of get conversations going, start to highlight these kinds of clinical issues at policy level for politicians and for related organizations. So a green paper is there to stimulate debate and discussion, both within our professional groups, but also across that wider health and care community. Start to outline where we think perioperative care should be going in the next 5 to 10 years. And to do that, we have to frame the narrative. So all this kind of, policy kind of jargon, developing compelling narratives, telling those stories, involving patients and the public in telling the stories. So then we can start to engage people within policy to make those stepwise changes for the future. So this green paper, what it includes is making the case for perioperative care. And we've done that by conducting some evidence reviews, which again, you can access through the Cpoc website. Describing the state of the nation and where we are now. So illustrating some of the case studies which exist out there, demonstrating how we could do this differently. But also then kind of really describing whilst we describe the opportunities and our priorities, also describing the challenges that we face as clinicians on the shop floor. So then we can start to address some of those barriers and look at the enablers for that. Within the paper, we also develop future gazing, so that vision of where we want to go. And importantly, we also start to develop a spending review approach as well. So these are some of the things that I've kind of discussed already. So clearly, Lisa had put them out separately in her slides. But kind of the bits that I haven't mentioned is how we're then also starting to engage both at parliamentary level and with stakeholders, and the comms that are required around that. So the work already has led to several meetings with politicians, with organisations such as the King's Fund, this institute who kind of taken over from Health Foundation type work, and also with other groups such as the Policy Exchange, who kind of act as kind of lobby groups. And it's really important to get the ear of those groups so that you can start to get these messages appearing consistently in the messaging going up to the Department of Health. It's also led to some publications, some invited editorials, and that's the kind of thing that we really are focusing on now, is getting the comms out around this. Lisa and the team are really working hard now on the spending review. So this is something that is of the order of, £2 to £3 billion worth of funding, where we start to outline what our main priorities are, what the benefits will be to our patients, but also to wider society as well, how much we think it's going to cost, but how we could pay for it. And then also illustrating how, as professionals, we are bought into this kind of approach, so that we've got buy-in across the professional group, as well as from patients, the public, and policy makers as well. So the way that Lisa and the team are really focusing on developing this is through surveys and focus groups with a variety of different stakeholders, writing discussion papers, sending them out to relevant organisations for further consultation, working with health economists at the modelling that's required around this, and then engaging with events like this so that we're getting this information out to the wider group, so that we can start to hear back from people as to what they'd like, what are the barriers, what we can be doing to support them. So that's a quick kind of run through some of the work that Cpoc has already been doing, and also some of the policy work that's now being developed as well. We're really keen on hearing from everybody out there. So there are the websites there. Feel free to email us directly at Cpoc, or me personally as well, if that's easier, because we really do want to have as wide engagement as possible in developing the work of Cpoc in terms of, the guidelines and all of that kind of stuff, but also in terms of future policy work as well. Thank you.